My name is Dr. Ajibola. In this video, we'll be talking about de novo pyrimidine synthesis. And if you remember from the previous video, we said pyrimidine nucleotide, there are three, and the mnemonic is cut the pie. The C there is salicylic acid, the U there is uridylic acid, and the T there is thymidilic acid. And those are three things that we want to produce. And let's look at the substrate that we have here. So starting with the pathway, we have the carbon dioxide, we have the glutamine, and we have the ATP. And if you have the supplemental material, I'm actually on the page 2 of the supplemental material. So these three things, they have to combine together to form carbamoyl phosphate. And the name of the enzyme here is carbamoyl phosphate synthase 2. And this is actually the rate limiting step. So this is the rate limiting enzyme. This is the rate limiting step. And that means this step is going to be tightly regulated. And anytime you see an enzyme ending in synthase, from the name of the enzyme, you can actually know what the product is going to be. So from here, like, we have carbamoyl phosphate synthase 2, so the product is going to be carbamoyl phosphate. The same thing too here. If you look at UMP synthase here, you can see the product here is also UMP. Thymidylate synthase, we can also see the product here is thymidylate. Methionine synthase, we can also see that the product here is methionine. And let's continue. So like I said, this is going to be the rate limiting step, and this reaction actually occurs in the cytosol or cytoplasm. And the reason why I mentioned that is because we also have CPS1, which is carbamoyl phosphate synthase 1, and CPS1 is located in the urea cycle, and that's the rate limiting step of urea cycle. So when we get to urea cycle, we want to talk about that. So please don't forget, the CPS2 is the rate limiting step of pyrimidine pathway, and is located in the cytoplasm, as opposed to CPS1 is the rate limiting step of urea cycle, and that one is located in the mitochondria. And also be the fate of carbamoyl phosphate. So from carbamoyl phosphate, we want to add aspartate to it through multiple steps by the help of dihydroorotic dehydrogenase, and we want to produce orotic acid. And orotic acid, PRPP, is going to donate ribose 5-phosphate to it. So PRPP is going to donate ribose 5-phosphate to it to be able to form UMP. And don't forget, the source of the ribose, one of the source of the ribose 5-phosphate is actually from the HMP shunt. So we're actually going to talk about this one later. So from the HMP shunt, so donating the ribose 5-phosphate to PRPP, and the name of the enzyme that helps us to be able to form is PRPP synthase. So that's the name of the enzyme here. So PRPP synthase, and then PRPP is phosphorybosyl pyrophosphate. So that's PRPP. And then from here, we want to now form UMP, and the name of the enzyme here is UMP synthase. And remember, like I said earlier, anytime you see synthase, so from the name of the enzyme, you can actually know the product we want to be producing. So that's the UMP. And also be the fate of the UMP, we want to add 1 phosphate to it, and once you have 1 phosphate, we want to form UDP. And then from here, so we want to become uridine diphosphate. From here, we can form the CTP, which is the thymidilic acid, or we can reduce the ribose that is inside there to deoxyribose. So this ribose that is here can be reduced to deoxyribose, and the name of the enzyme comes from the reduction of the ribose sugar that is inside the UDP, and that's the name of the enzyme, the ribonucleotide reductase. So we want to reduce the ribose sugar in the UDP to DUDP, so that we'll be able to form deoxy. And also be the fate of deoxy UDP. So we want to remove 1 phosphate, and we want to now form the UMP. And from the UMP, we want to now make our dTMP, and that's the thymidylate right there. And the name of the enzyme that converts, so you can see the major difference between this and this is we are changing the U to T, and the name of the enzyme there is thymidylate synthase. So that's the name of the enzyme. And for this reaction to occur, we require a carbon, and the reason to donate the carbon is folate. So that's the role of folate in this pathway. So no folate will not be able to produce, will not be able to have this last conversion. And let's quickly look at this side and let's talk about folate. So the metabolic form of folate is methylene tetrahydrofolate. So that's the metabolic form, and that actually wants to donate the carbon to this last pathway. And don't forget, side note, remember folate is a carbon transfer, so it always helps in transferring carbon to any reaction that needs it, like this last conversion. And so you want to transfer the carbon to this last reaction so that you'll be able to form the dTMP. And once you transfer the carbon to this reaction, it's going to go into oxidized form, and that's dihydrofolate. And then for us to be able to use it back, we need to reduce it back to a reduced form. And then the name of the enzyme, we want to convert it back to a reduced form, so like we're reducing it. So it's going to be dihydrofolate reductase. So dihydrofolate reductase converts dihydrofolate to tetrahydrofolate. And this tetrahydrofolate now, so this amino acid is going to donate methylene back to tetrahydrofolate, which is serine. So we'll be able to form our methylene tetrahydrofolate so that we'll be able to use it again. And then once it donates the methylene group to the tetrahydrofolate, it's going to form glycine, which is another amino acid. And we can use amino acid for a lot of glycine for a lot of things in the body, like for instance using collagen synthesis. So collagen synthesis. So glycine is used in collagen synthesis. I'll talk about collagen synthesis in the next lecture, or maybe probably in the later video. So let's continue. So let's come here. So we can, here we have methyl tetrahydrofolate, and methyl tetrahydrofolate is a circulating form of folate. So this is circulating form of folate, and it can actually replenish the tetrahydrofolate that we have here. And I want to replenish it, so we need to donate the methyl to vitamin B12, which is cobalamin. And once you donate the methyl group to the vitamin B12, it needs to become tetrahydrofolate. And so vitamin B12 needs to now become methylcobalamin. So it needs to become methylcobalamin. And also be the fate of methylcobalamin is going to donate the methyl group to homocysteine, so that homocysteine will be able to form methionine. And the name of the enzyme there is methionine synthase. And then sometimes in some texts you can see here, instead of putting methionine synthase there, they'll put homocysteine methyltransferase. So homocysteine methyltransferase. It still means the same thing, because the name of the gene right there is homocysteine methyltransferase gene, and it's actually the one that codes for this enzyme that we're actually using to convert the homocysteine to methionine. And also be the fate of the methionine. The methionine we can add ATP to it and form SAM, and then SAM is S-adenosyl methionine. And what do we use SAM for in our body? Don't forget, SAM is a universal donor of methyl group. So for any reaction that require methylation, and a classic example of reaction that require methylation is a conversion of non-epinephrine to epinephrine. So that last conversion actually requires methyl. So the SAM is going to donate methyl group to that pathway, and that reaction is methylation reaction. And also be the fate of homocysteine. So homocysteine, so like I said, we can convert by the help of donating methyl to homocysteine, we can form methionine. Also homocysteine can also be converted to cystathionine by the help of cystathionine synthase. And then from there we're also going to form cysteine. And to be able to convert, for this conversion to occur, it requires another vitamin here. And the name of this vitamin is vitamin B6, and that's pyridoxine. And you can actually see here that there are three major vitamins that actually helps us to reduce homocysteine or conversion of homocysteine in our body. One is vitamin B6, another one is vitamin B12, and the last one is folate. And if somebody has deficiency of vitamin B6, vitamin B12, and folate, they can actually have increased homocysteine in the body. So please don't forget, three vitamin deficiency that can lead to increased homocysteine in the body includes vitamin B6, vitamin B12, and a folic acid. So the deficiency of these 3 vitamins can lead to increase in homocysteine in the body. Another condition we are also going to talk about later is if there is deficiency of this enzyme. So if there is deficiency of this enzyme, we can also have increase in homocysteine in the blood. And don't forget, increased homocysteine is not fun at all because it can actually damage the endothelium, which can actually lead to what it can damage the endothelium, which can lead to arteriosclerosis. And that's why increased homocysteine is one of the risk factors for arteriosclerosis. So it's actually iatrogenic. So let's go back to the part. Let's start from the beginning again, and let's start talking about the pharmacology and the pathology as well with the pathway. So starting from here, we can see the first enzyme we mentioned here is CPS2. So that's carbamoyl phosphate synthase 2. And don't forget, we said that this one is located in the cytoplasm as opposed to CPS1, which is the rate limiting step of urea cycle, and that one is located in the mitochondria. And like I said earlier, this is the rate limiting step of the pyrimidine pathway. So that means we also have things that want to be inhibiting or stimulating it. And one of the things that can actually inhibit this pathway is UTP. So uridine triphosphate. Mentioned. So the products actually kind of like inhibiting regulating the enzyme here. Another thing that can also stimulate this pathway is ATP. So ATP can stimulate this pathway, and it can also be stimulated by PRPP. So PRPP. So those are the things that actually regulate this enzyme. And let's go to this place. Now we also say that carbamoyl phosphate is converted to orotic acid by the help of aspartate. So you can see, so here we are using glutamine. This is also another amino acid that we also use in production of pyrimidine. So glutamine aspartate. And the name of the enzyme that helps in conversion to orotic acid is dihydrofolate dehydrogenase. And there's a drug that can inhibit this enzyme, and the name of the drug is leflunomide. So leflunomide actually inhibits dihydrofolate dehydrogenase, and we can use leflunomide for chronic inflammation like rheumatoid arthritis and so on and so forth. And let's come here. So orotic acid, what's going to be the fate of orotic acid? Like I said earlier, PRPP is going to donate ribose 5-phosphate to it, and then by the help of UMP synthase, we want to form UMP. So for instance, let's say somebody have deficiency of UMP synthase. So if a patient has deficiency of UMP synthase, that means you'll not be able to convert orotic acid to UMP. So if you can't convert orotic acid to UMP, then we have to have accumulation of orotic acid, and that's where the name of the disease comes from. So the disease is called orotic aciduria. So we call it orotic aciduria. And in orotic aciduria, you have increased orotic acid in the blood and also increased orotic acid in the urine. And then another thing, if you notice here, is that so that means you'll not be able to produce UMP, and no UMP will not be able to produce CTP, cytidilic acid, and will not be able to produce thymidilic acid. And these guys, they are required for DNA making. So that means you want to have problem in DNA synthesis. And because of the problem in DNA synthesis, that it can lead to megaloblastic anemia. And that's why orotic aciduria or UMP synthase deficiency is one of the causes of megaloblastic anemia. And this form of megaloblastic anemia we have here is not going to respond to B12 and folate administration, because the problem here is upstream here, it's not downstream here. Where we require folate and B12 is the last conversion, not up here. So if somebody have deficiency of UMP synthase, that means they're not able to form UMP, and that can actually lead to megaloblastic anemia. So what are you going to see in patients with orotic aciduria? One, they want to have increased orotic acid, and they also going to have increased orotic acid in the urine. They also going to have megaloblastic anemia, and this form of megaloblastic anemia is not going to respond to administration of B12 and folate, and that's why the treatment for this condition is to give them uridine, which is UMP. So to give them UMP, so that's actually what they are not producing. And like I said earlier, this UMP can feedback and inhibit this enzyme here, thereby decreasing production of orotic acid in their blood, in this pathway. Another condition that I also want us to be aware of is OTC, and OTC is ornithine transcarbamylase enzyme. And what's OTC doing? OTC is actually what allows us to be able to add so OTC is present in the urea cycle, and this is what actually allows us to be able to add ornithine to carbamoyl phosphate to be able to form citrulline. So, and that's what we see in the urea cycle. So let's look at this little pathway I put by the side. So this is actually the pathway of the urea cycle. So this is not everything. This is just, I just selected the one that is important to this pathway we are talking about. So when we get to urea cycle, we want to talk about the rest of the pathway. So this is actually like a mini form of the urea cycle, and this takes place in the liver. And here, so this is the mitochondria here. So this one happens inside the mitochondria, and this one happens inside the, so this to this cytoplasm. And here we can actually see our CPS1, and like I said earlier, so CPS1 is the rate limiting step of urea cycle, and but this one is located in the mitochondria. Remember, as opposed to CPS2 that is located in the cytoplasm. And another thing I also want us to notice here, you can see here we are making use the guy that is donating the nitrogen here is actually ammonia, as opposed to in pyrimidine pathway, the guy that is donating the ammonia there is actually glutamine. So if you actually remember, you can see we saw glutamine here, and that's glutamine right there, but here it's actually ammonia. So let's continue. So like I said, anytime you see synthase, so from the name of the enzyme you can actually know the product. So you can see what we are producing here is carbamoyl phosphate, and by the help of ATP. So the carbamoyl phosphate, now we want to now add ornithine to it, and by the help of this enzyme we want to form citrulline, and the name of this enzyme there is ornithine transcarbamylase. And at the end of the day we want to form urea, and urea is renally excreted, so we can actually excrete it through the kidney. So for instance, let's say somebody have deficiency of this enzyme, the ornithine transcarbamylase. So if there's deficiency of this enzyme, that means we will not be able to convert carbamoyl phosphate to citrulline. And because we can't convert carbamoyl phosphate to citrulline, so that means we're not able to convert our ammonia into urea. So that means this guy, they want to have increased ammonia, so they want to have hyperammonemia. So that's one. And this carbamoyl phosphate will now be shunted to this pathway. So if it's shunted to this pathway, so what are you using carbamoyl phosphate to produce? We are using to produce orotic acid. So that means in this condition, they are also going to have increased orotic acid. You want to have increased orotic acid. And but don't forget, here because the problem is not inside the pyrimidine pathway, it's not going to affect DNA making. So that means here we are not going to have any megaloblastic anemia. So let's quickly compare both of them. So in OTC deficiency, ornithine transcarbamylase deficiency, we want to have increased ammonia because the problem in the urea cycle. We want to have increased orotic acid because excess carbamoyl phosphate that we can convert to citrulline will be shunted to pyrimidine pathway, and we want to use to produce orotic acid. But they are not going to have any megaloblastic anemia because it's not a problem in DNA making. And as opposed to the one we have in the pyrimidine pathway, so in the pyrimidine pathway, if somebody have UMP synthase deficiency, so that means they want to have increase in orotic acid, but there will be no hyperammonemia because it's not a problem in the urea cycle, because urea cycle is still functioning. And but here, because you can't produce all this nucleotide, that means you want to have problem in DNA making, and that's why they want to have megaloblastic anemia, and that's the difference between both of them. And let's continue. So here we want to be the fate of our UMP, like I said. So we have to add one phosphate, we want to form UDP, and from this UDP is going to we are going to reduce the ribose there to deoxyribose, and the name of the enzyme there is ribonucleotide reductase. And there is one important drug that can inhibit ribonucleotide reductase, and the name of the drug, so it's inhibited by a drug, and the name of the drug is Hydroxyurea. So that's Hydroxyurea. And what do you use Hydroxyurea for? You can use Hydroxyurea for sickle cell patients. So in sickle cell patients, and the way it works for sickle cell patients is to increase the fetal hemoglobin. We can also use Hydroxyurea for all those chronic myeloproliferative disorder like essential thrombocytosis, polycythemia vera. This is actually going to also help them. And then looking at it, so in other words, that means Hydroxyurea can actually affect DNA making. That means patients who are taking Hydroxyurea, maybe you can see like a bone marrow suppression in them, because we want to have impairment in DNA making. And so let's continue. So from the UDP, you want to form the UMP, and like I said earlier, the UMP is going to be converted to dTMP. And the name of this enzyme here is thymidylate synthase. So the name of the enzyme here is thymidylate synthase. And there's one important drug that can also inhibit thymidylate synthase, and the name of the drug is 5-fluorouracil. So 5-fluorouracil actually inhibits thymidylate synthase irreversibly. And if you remember from pharmacology, from our discussion, anytime a drug is inhibiting an enzyme irreversibly, that means you want to have decrease in the what? In the V mass. So you want to have decrease in the V mass, but don't forget the Km is unchanged. And don't forget, like we said, Km is always a term for potency. So when we get to when I get to video of pharmacology, I'm actually going to talk about it. So let's continue. So don't forget, 5-fluorouracil inhibits thymidylate synthase irreversibly. And let's look here. Now we said that for this last conversion to be able to occur, it requires a carbon. I need to donate the carbon, so it's by the help of folate. So the methylene tetrahydrofolate. And we said that once you donate the carbon to this reaction, you have to go back to an oxidized form, which is dihydrofolate. And for us to be able to use the folate again, it needs to go back to a reduced form. And the name of the enzyme that also allow you to go back to a reduced form is dihydrofolate reductase. So the name of the enzyme is dihydrofolate reductase. And there are three drugs that can inhibit dihydrofolate reductase. So one of the drugs is methotrexate. So methotrexate inhibits dihydrofolate reductase. But as a matter of fact, methotrexate actually inhibits eukaryotic or human being dihydrofolate reductase. And that's why we can use methotrexate for abortion and so on and so forth. And then don't forget, because we are inhibiting folate, so that means it can actually also lead to bone marrow suppression. And that's why, to reduce the side effects of methotrexate, we give them what we call leucovorin rescue. So leucovorin rescue. And leucovorin rescue is actually folic acid. So remember, that's what we are. Remember, the major problem here is that we don't have folic acid. So once you give them leucovorin, which is folic acid, then we want to replenish this tetrahydrofolate again, which syringe can donate methylene to, and we'll be able to use it for this pathway. So the way we decrease the side effect of methotrexate is to give leucovorin rescue, and that's folic acid. And another drug that also inhibits this pathway, is pyrimethamine. So pyrimethamine, and then pyrimethamine is actually inhibiting protozoa dihydrofolate reductase. So it's inhibiting protozoa dihydrofolate reductase. And the last drug that also inhibits this pathway is trimethoprim. And trimethoprim is an antibiotic. So this one is inhibiting prokaryotic or bacteria dihydrofolate reductase. And don't forget you can combine this one with other drugs. So let's continue. So looking at here too, so we can see for this last conversion we require folate and we also require vitamin B12, because remember the circulating form of folate is methyl tetrahydrofolate, and if there is no vitamin B12 to give the methyl to, you'll not be able to go to tetrahydrofolate, so that will be able to form methylated tetrahydrofolate. So that means if somebody have B12 deficiency or if somebody have folate deficiency, that means we will not be able to convert the UMP to dTMP, and this can actually lead to decrease in DNA synthesis. And that's why in someone who have folate deficiency or B12 deficiency, then they can also have megaloblastic anemia. And three things that we mentioned that can cause megaloblastic anemia: one is UMP synthase deficiency, so deficiency of this enzyme, or somebody who have B12 or folate deficiency. So this guy, they can all these three guys we mentioned, they can all have megaloblastic anemia. But don't forget the orotic aciduria, this one cannot be corrected by addition of folate or B12, so you'll not be able to correct that anemia. So I think that's all about this pathway. So the next video we'll talk about purine synthesis. Thank you.